All right, many thanks, Oyeyemi Ajayi, for that background report. And to begin our conversation this morning, let me introduce here in the studio Dr. Garba Ahmed Rufai, Director, Disease Control and Immunization, National Primary Healthcare Development Agency. A pleasure to welcome you to Good Morning Nigeria.
Thank you. It's a pleasure to be here.
Okay.
And we also have joining us for the conversation, but via Zoom, Dr. Ganiyu Jamiu, the Chief Consultant Epidemiologist, Federal Ministry of Health. Many thanks for joining us, sir.
Thank you very much. Good morning, everybody.
All right, thank you, Doctor. And we also have Professor CFR Brisibe, the Commissioner for Health, Bayelsa State, and co-chairman of the National Emergency Medical Treatment Committee for the National Emergency Medical Service and Ambulance System in Nigeria. Many thanks, Prof, for joining us.
Yeah, thank you. Thank you for having me.
Great.
All right, thank you very much. Let's begin the conversation here from the studio. Let me ask Dr. Rufai, where are we with combating Mpox in Nigeria?
Yeah, thank you very much. Currently, we have a multi-agency task force, which was activated, the monkeypox EOC. In time past, it was deactivated when the cases are actually completely zero in Nigeria. But as we stand right now, we know that 19 states are reporting out of 30 LGS. So there's a reactivation of this task force, which combines with the government, partners, and all of our international donors. It has become a public health emergency globally. So here we are, we have developed documents around how we manage this condition and disease, and what the public should also do. On the long term, vaccinations will happen, but in the meantime, it's also very important that Nigerians understand that yes, this is a disease that has come, and it is infectious. It is in Nigeria. It is in all of the states, whether you are in northern or
All
south. No,
of the states.
what I mean by in all, it can, because of our migrant nature moving, so it can go to every state. So we have reports from 19 states already. You can imagine when it came, and it's already in 19 states. So yes, so we as the National Primary Healthcare Development Agency, we're collaborating with the NCDC, which is primarily mandated with surveillance for vaccine preventable diseases and all of the other diseases. So we're working with them in terms of developing IEC materials to be able to educate Nigerians, and also to increase our sensitizations at the local levels, beyond the federal level, the subnational levels, up to the interiors, the villages and all that. So we've also put in place measures at primary healthcare centers, which we have direct relationships to. We're conducting sensitization, we're doing screening for any suspected cases. We've been able to train health workers in terms of what this disease is about, what they should look out for. And yes, we have also designated some centers as referral centers for suspected cases where tests would now be conducted and a confirmation can now happen. And in these isolated centers, we now have what we call isolation units, where suspected cases are isolated, they manage until they get well for now. We all know that we received vaccines for monkeypox. It was a donation from the United States government that happened on the 27th of August. And as we speak now, there's a what we call a deployment plan for that vaccine. But what we're waiting for NAFDAC, who has taken some samples to do some testing, and to now give, they are the ones to give the go-ahead to say, yes, these vaccines can be used in Nigeria. So before the vaccines, it is important to put it out there that, yes, the sensitization includes what needs to happen, what are the symptoms that if anybody sees, they need to quickly report to a health facility. And some of the symptoms were listed here. We have fever. This is not just fever, high-grade fever, 38.5 degrees centigrade, which is what they call high fever in Common Palace. He has intense headache. It's really intense headache. Body pains, the one and the doctors who call myalgia. Then on examination, find some lymph nodes. These lymph nodes usually do not get enlarged except there's an infection. For monkeypox, they promptly come out, and yes, so the health workers actually know what to do. So we're also advising the health workers also to make sure that they actually do what we call IPC, infection prevention control measures. Wear gloves. So now we have what we call the high index of suspicion. So somebody comes with a fever, normally Nigerians will come and say, I have malaria, just because they have fever, but not all fevers are malaria at the present. So Nigerians need to know that. So our health workers look out for when they have anybody that has
because
fever.
some can now present as Mpox.
Yes, exactly. So the fever could be as a result of Mpox. It's not necessarily malaria that Nigerians always do and go to one chemist to go buy one of those tablets and just drink. But Nigerians need to go and see a health facility worker to be able to ascertain that this is not malaria. And of course the rash, which is quite typical. You can't miss that.
Okay.
So it's a combination of effort, and it's multi-sectorial right now.
Okay, I'd like you to give us, just a brief explanation of how this disease, manifests and all of that. And then, is it treatable? Because you were talking about isolation centers and all of that. Of course, we know, yes, transmission is possible, to other humans. And tell us how fast that is in terms of transmission. And if treatment is available in the country at the moment. And then you talked about training medical personnel. I want to know, are you training medical personnel in tertiary health facilities or those at the primary health care center? Because we know that a lot of people, their first contact with a health facility is usually the primary health care center. So if there's no enough awareness at that point, then we may have a crisis in our hands.
So I would start from, yes, okay, the disease. Well, it's a well-known fact that it's a zoonotic disease. What it means that the virus actually was discovered in animals and it's been transmitted to humans. But now there is also the human-to-human transmission, which is by close contact, some respiratory droplets, body fluids. So it's also transmitted through sex, transmitted through kissing, and co-use of things like towel. So if one person, if an individual is infected and excuse me, has some of these lesions and uses a towel and another person uses it, especially that we'll never know, you can't see some tiny breaks. So those body fluids can now, the virus is in the body fluids and now get transmitted to the next person. And yes, that happens. I actually listed some of the symptoms that you can see. So in terms of treatment, in medical terms we say, okay, it's manageable. So treatment is usually symptomatic. Try to bring down the fever using analgesics and treat the sores. And make sure that the patient is as comfortable as possible. Make sure the person still eats, gets food, and be able to maintain, and also get hydrated. That's also very important. So isolation is to reduce transmission. It's not to provide or to promote stigmatization. I need to bring that out because that's a major problem in Nigeria. Somebody has a rash and all of that, people start running around, and those rashes are pretty disfiguring. It looks like this person. The way Nigerians have usually stigmatized all of this. So it's usually better when somebody is a suspected case. Before anything happens, it's best that the person is properly examined and test conducted and the person is now treated. Then the person can't be let go when it is confirmed that it is not monkeypox or it has resolved. Yes. And then in terms of your training, so I want to say this, as National Primary Healthcare Development Agency, we have I think we have the largest footprints in terms of structures beyond the federal level. So we have folks that we work with at the state level. We have also state primary healthcare board who are directly responsible for those primary healthcare centers in those states. So we work with those state structures to also be able to train these health workers. So yes, health workers at the subnational levels, at the primary healthcare centers, know these signs that they need to look out for. So we have aids that are on the wall, so in case you forget, you easily just check once you see a client coming in. And all of the other issues around IPC. So they also trained on IPC measures to ensure that, yes, first things first, do not say, oh, this is my brother or my sister or my cousin. Please wear hand gloves, wear a face mask when talking to any patient at all. For the period that we're in right now, it's supposed to be a usual practice, actually, at IPC, at health facility, even at the homes, cleaning of surfaces normally. Just be hygienic. Wash your hands with soap and water. Yes. So that's where we are at. The workers at the health facility are trained. They have job aids to remind them. Then we have also activated structures in terms of surveillance. We built up surveillance to be able to detect from the communities, also from the health facilities.
Okay, yeah. Dr. Rufai, thank you very much for your opening remarks. Let's get to Professor Brisibe, who's joined us from Uyo. Prof, you're Commissioner for Health in Bayelsa, in addition, of course, to the national assignment that you have with the National Emergency Medical Service and Ambulance System. What's the situation specifically in Bayelsa, and how is the healthcare system dealing with it?
Yeah, thank you so very much for having me on this platform to talk about this. In Bayelsa, what after the early 70s, when Mpox, monkeypox, was discovered in Nigeria, the next time it was in 2017 when it became an epidemic level, and the index case was diagnosed in Bayelsa State. So somehow we're used to it. And then the other thing is that we have one of our infectious disease consultants that is at the forefront of doing this. So on the 14th of August, of course, our surveillance system has been a little bit quite okay. So on the 14th of August, when the World Health Organization declared this as public health disease of international concern, what we did was to see that we reactivate our public health emergency operational center. And of course, before then, from January to uh, 86, and out of this, of course, 5.
So it looks like we have a connection challenge with the Honorable Commissioner for Health, Bayelsa State. When that is rectified or strengthened, would definitely get back to him. But let's get to Dr. Ganiyu Jamiu now. I want to find out, Dr. Ganiyu Jamiu, do you think that we should be worried about the clade, if you like, the variant of Mpox that we have with us? First and foremost, tell us the clade that is present in Nigeria, how it behaves, how fast it's likely going to spread, and what are the factors, that could aid, this virus from infecting more people and, of course, spreading to more states. Do you think the weather condition is a factor away from, personal hygiene, which Dr. Garba has already mentioned? Just let us know, all about the clade that is present in Nigeria at the moment.
Thank you very much. Whenever there is a new variant of a known viral infection, it usually causes worry. In especially for the major stakeholder and for the country, at the global level. But you'll believe with me that this is not the first time we are responding to an outbreak of such nature. We've had experience before. Professor from Bayelsa mentioned the fact that we had an outbreak sometime in 2017 and up to 2020. So based on our experience, we think we're relatively prepared for this. It's just that based on epidemiological findings, it has proven that the current variant YE, the new variant class 1E also is said to be more common among men who sleep with men, and I want to believe that with that we are more. That shouldn't be a concern for us because we've had a lot of programs that actually take care of such category of people, and I want to believe that with the supply of this vaccine, it will go a long way in ensuring that those category of people and other high-risk groups benefited from the vaccine after the approval from NAFDAC. So I think, and again, looking at our surveillance system, I want to believe that it is robust enough to be able to, capture the whatever cases that may be coming up. Looking at the community-based surveillance, looking at the facility-based. We have two types of surveillance, the case-based and the indicator-based, which I think they are very strong enough, which are keen into the IDS, and that is the integrated disease surveillance and response the strategy that we have actually, implementing in the country. I think we are more prepared. And one of the key things we did was the Hello.
Yeah.
One of the another step taken was the issue of
I'm in a program.
using using the
All right. I think we're having a little jam at that end between the Zoom guests. But let's come back to the studio here where Dr. Rufai is still seated. At least there will be nothing like jam connecting with you.
So I hope not.
So, but talking about the vaccine, which Dr. Jamiu had talked about before we went off him, how much of it do we have, and is it likely to achieve the results that we expect it to achieve, beginning with the numbers?
Yeah, well, we'll start with the numbers that we have. So we had a donation of 10,000, round figure. Some of that needed to go to NAFDAC for testing. So we have less than the 10,000, a little less than. So we had to give like 20 of those doses. So we have currently 9,990.
Almost 10,000.
Yes, almost 10,000. So yes, that's what we have in country right now. And for that, we're not going to go all out to, at least currently, all out to do what we call mass vaccination for everybody. That will not be enough
to target it.
Our population. So based on the epidemiology and what the disease trend shows us, so those states that are mostly affected are the states, the Bayelsas, the Cross Rivers, the Ogun, the Lagos, and all of that.
Why are those states more affected?
That's where the disease has been seen. Having to go to why, a why is not something you could place your hands on, but we would say that this disease, knowing how it is spread from animals and also the human contact, so it's possible that, yes, we have folks who maybe handle animals more around those areas. They actually found from rodents, it was actually saying, yes, it's monkeypox that was seen in the 50s, but however, the host for this virus is squirrel. That was what was found. But there's this interaction between animals within forest and all that. So yes, for folks who actually deal with animals, mostly that's where it is higher in terms of transmission. And you heard all of the other things around sexual behaviors, multiple sex partners, and all of that. So yes, so that comes to play also in terms of the transmission.
So those states that are likely going to get the vaccines, is it those who are already infected with Mpox that will get it, or those who have come in contact with those who have it?
Exactly. So it's a viral disease. So, and it's highly infectious. So the major thing around surveillance, first thing first, is to first of all do contact tracing. When a case is found, it's very, very important to do. Who are the people that have been in contact with this individual? Where does he stay? Who are his friends? Who are his family? And all of that. So those will be the first
to be vaccinated.
To get vaccinated. So priority is given to them. Also, our health workers that are our first line of defense in case of any of these diseases. Also, it's also important. So part of the plan is to also vaccinate health workers and also contact on, we do what we call ring vaccination, because we have very limited quantities for now for around that individual, families, close contacts and all of that.
But how safe are these vaccines, you know, away from the testing that NAFDAC is trying to do? Because there's this conspiracy theory about vaccines and, you know, Africans reducing population, using vaccines and all of that. This particular Mpox vaccine, you know, looking at the source and how fast it's here and all of that. I mean, what's your reading of it, and what would you want to tell Nigerians?
I want to tell Nigerians to stop listening to non-professionals, to stop listening to mischief makers. So let me put, before this vaccine, before the disease was declared as a global health concern, we had already made plans for these vaccines to come to Nigeria. It's not like, oh, because it was now declared, that's where the vaccines come. No, we need to get that clear. We are already stockpiling this vaccine because we from the trend of disease of spread of disease, we're already seeing that monkeypox was in countries that were close by. And we know that these diseases, they don't make phone calls before they come to you. They just cross over. It's just one person that moves. We remember the Ebola issue. It was just one man, and it became a really big issue. So yes, there is no conspiracy to it. And I keep saying this. We've started this conspiracy theory in Nigeria from 2003. For the polio case, it was a really big case. I said it was going to cause infertility and all that. Where did that happen? In Kano. I'll ask the people of Kano. The children that took the vaccine in 2003.
How many children do they have now?
Exactly. We know how populated Kano is. I used to work in Kano. There are places you go to, you need to park your car because the children, they're everywhere. So if if vaccines actually cause infertility, then I think we should go check what's happening in Kano. There's nothing like that. It doesn't happen. But we know vaccines work. The science proves it. Smallpox has been eradicated because we use vaccine. It is clear.
Okay. But the numbers we have, just to make it clear, given your analysis, doesn't quite scratch the surface. By the time you deploy some for, you know, those on first line duty, you trace this and trace that, you probably have the whole 10,000 vanished.
Exactly. But that is not the end of it.
But why are we not getting more, though? Why are we unable to access
It's not why are we not getting more. We're making plans to get more. African CDC is supporting us to get more vaccines as we speak right now.
Will the vaccines be free?
Definitely. From the federal government, yes, vaccines are free.
All right. It's important to get that clear. Yes. Let's get back to Professor C.F. Brisibe. I'm sure you're back with us and you can hear us loud and clear. Prof, before the disconnection, you were trying to tell us what Bayelsa State is doing, and listening to Dr. Rufai, Bayelsa State has quite a number of cases of monkeypox. So tell us, what is going on in Bayelsa at the moment, and what's the government planning to do?
Yeah, okay, thank you for having me back. So presently we have 106 suspected cases in total, and out of that we've gotten 6 of them tested positive. So what we are doing is that we've reactivated the emergency public health emergency operation center. We have upscaled our surveillance, and also we've also procured PPEs, and then also essential medical commodities for treatment. We've also tried to see that our isolation center is functioning. But all this, we are doing it on 3 basic fundamentals, and that we believe that first, the first fundamental is that we want to stop people getting infected by engaging in advocacy to change behavior, to see people have what it takes, wash your hands, don't eat uncooked meat, and then, of course, because so we are doing that on that front. The second fundamental is that even when somebody have it, we must mitigate transmission, person-to-person transmission. So, and that is why we are deploying the PPEs and also educating our public and then health workers, retraining them. Then the last framework is that, look, even when we have this, if somebody is infected, we should keep it at 0 mortality. And of course, the isolation wards and then the disease surveillance framework that is active every morning, including One Health platform. We all have a conversation around what is happening, and then deploy these essential medical commodities to all our centers. And luckily for us presently, in all this, we are able to have the fact that
Prof, we honestly cannot explain what's going on, but I'm sure that all of that... all right, Prof, looks like you're back with us.
Yeah, I'm back. Okay, so sorry for, So those are some of the things we are doing. And we are also grateful for the fact that presently we have vaccines distributed by the U.S. government, and we are also prioritized as one of the states that is going to have that. So we'll also engage in that training and also advocate, because of course all of us understand the conspiracy theory around vaccines. So we need to advocate to our public and then even the health workers, the frontline health workers, that we are going to prioritize in having these vaccines, that look, this vaccine is safe and is not going to cause any problem. And of course, the government has been very, very supportive because in all this, we've been able to mobilize funds to do what we're doing. If you get to Bayelsa now, the local jingles we have in our local dialects and languages to sensitize and also see that people's behavior in terms of getting hand hygiene come back, and also in terms of having meat properly cooked, and then of course preventing getting to people that close contact. So that all that is being done. We also believe that as we do all this, we must not stigmatize people, because of course, you know, these issues of stigmatization, even when cases are not confirmed, once you just say this is Mpox, a lot of people tend to run away. We are also trying to see that does not happen, even as we preach against contact. But of course, the lesions, when you have them, the rashes, immediately after the treatment and you recover, you see that these lesions go. So some people also have this belief that these lesions are not to go. So we are also engaging all that as our treatment framework. So those are some of the things we are doing. And of course, like I said, it's basically to see that with any mortality, and then also mitigate person-to-person transmission as well.
Fantastic. Professor Brisibe, of course, we can see that, or rather we can hear, we hope to see all of these actions in place. But you talked about the jingles, you know, in the different dialects. But you know that there are so many challenges as regards that. Just maybe a few people who have power supply and all of that may be able to hear those jingles. Are you in touch with community leaders? You know, the way Bayelsa is, you know, just so that those in the hinterlands who are likely going to be more affected if this gets to them, get to hear this message as fast as possible and understand it. Are you doing all of that? Are you getting health workers, you know, to reach out to people in their communities, you know, just to get them informed?
Yeah, you know, Bayelsa health system is one that's mainstream public health, and also we have a very strong buy-in platform that we have created in all our facilities, including the primary healthcare facilities and then the secondary healthcare facilities. We have what we call healthcare facility committees, management committees level, and then at the primary level we have the World Health committees. These committees are made up of traditional leaders, opinion leaders, the head of these the facilities. Of course, it was basically created to ensure that we have uptake of these services provided by these facilities. Therefore, we are using that platform actively as we speak. And that is one reason why you see that in Bayelsa, we have a high number of suspected cases. In fact, the whole state, the whole country outside Ogun State, we have the highest number of suspected cases. And the reason for that is because our communities, we are working with our traditional leaders, we are working with our opinion leaders, the CDCs in our various communities. So we have a very high rate of patronage and turnout to these facilities in our communities. So that is also already something that we are doing actively. It's part of our framework, because the framework for us is that, look, we should be able to build a strong and resilient health system. Therefore, before shock, we operate, before any public health emergencies, anything, we operate maximally. And in case we have very serious public health emergencies, we should be able to operate minimally and restore immediately after those crises. So it's on that platform that we are doing all this. So the community buy-in, the community involvement, the leadership, opinion leaders is top-notch.
Professor Brisibe, thank you very much for those comments. Let's quickly get to Dr. Jamiu, who also has joined us via Zoom. Taking a cue from Bayelsa, courtesy what Prof has outlined, what else should states do? Because when we are able to mitigate Mpox across states, then we probably won't have a national emergency.
Yeah. I'm not hearing, please. Can you just repeat it again?
Taking a cue from Bayelsa, what more should states do? Because therein lies our capacity to deal with Mpox. If you're able to mitigate it at the state level, then dealing with it at the national level will be almost a foregone conclusion.
Yeah, I agree with you. You see, what is happening in Bayelsa also applies to every other state. The capacity in pandemic response in Nigeria, the capacity of the state has been strengthened in terms of human capacity, laboratory capacity, surveillance, and other logistic-wise. So whatever you see happening in Bayelsa is not surprising to us, because that is what the government actually, our mandates, and as well as our target to see that states can manage outbreak on their own, which many states are able to carry down. This is example of what's happening in Bayelsa is not only that of Mpox. We've had cases of other outbreak like cerebrospinal meningitis, heavy metal poisoning, and so on. And states have taken that bold step, that leadership, to ensure that they manage it with limited support from the national. So I want to assure you that what is happening in Bayelsa is not peculiar to them. Other states' capacity have also been built to be able to manage outbreaks. So I'm not surprised with that. And I want to assure you that whatever is happening in Bayelsa is also applicable at the national level in terms of ensuring that we need Mpox on board. And I want to make it very, very clear again on the issue of what you just mentioned. Yes, risk communication is very, very important. We need, and also, I want us to understand the fact that Mpox is not a new thing to us. It is something that is endemic in West Africa and Central African countries like Nigeria. And the report that was being shared, that's currently being shared, and this data that been recorded from January this year today. So it is not that we are not aware of the fact that there is Mpox in the country. But what we are trying to do, just like Prof said, is to limit its spread so that we are not going to record more cases with accompanying morbidity and mortality. And I think that is what the Nigerian government is doing in terms of surveillance and ensuring that all the necessary things are being carried out. Then I want to make it again clear that there is, if in severe cases, there is availability of antivirals that can be administered to any severe cases to manage that, apart from vaccination. And also, was trying to make it very clear that the current variant are defined among men who sleep with men. And that is why we need to prioritize the category of people that will benefit from the vaccine. And one of those areas, those men who sleep with men. And I want to tell us, I came from the HIV angle before I became the current consultant epidemiologist. So we've been working in line with those program area that actually take care of those categories. That is the key population. And I think they will also benefit quite well as regards to that. Even the first case that was recorded in Bayelsa was in 2017. At the end of the day, we found that it was somebody that actually was involved in high-risk sexual behavior and so on. So I think we also need to critically look at those categories of people if actually want to reduce transmission. In addition to creating awareness and so on. And also, our mothers are very, very critical because the virus can spread from mother to child. We need to take critical look at that. It's very, very important so that we make sure that we also protect our mothers from getting.
All right. Thank you very much, Dr. Ganiyu Jamiu. It was great to have you on the program this morning. Because of time, we'll leave the conversation at this point. It's a continuous one, and we hope we're able to deal with Mpox just like we did with some other diseases as soon as possible. Thank you so much, Chief Consultant Epidemiologist, Federal Ministry of Health, Dr. Ganiyu Jamiu. Of course, Dr. Garba Ahmed Rufai, Director, Disease Control and Immunization, National Primary Healthcare Development Agency. Thank you so much for being our guest. We hope you continue to do your best just to keep the nation safe and healthy. Professor Siefa Brisibe, Commissioner for Health, Bayelsa State, and co-chairman of the National Emergency Medical Treatment Committee for the National Emergency Medical Service and Ambulance System in Nigeria. Thank you so much for being our guest. And yes, we hope that the number of cases would reduce in Bayelsa. Thank you so much. So we'll take a break. The second leg of the conversation. It's on cancer. Stay with us.
The federal government of Nigeria wants vandals